Thanks, Esther. No, thank you very much, and thanks for your introduction. So for those of you that don't know me, my name's DCI Larisa Hunt. I'm from Avon and Somerset investigations teams, and I've been working in child death for a number of years now, and until recently was our police panel member for the Child Death Overview panel. This is very much talking about your role in the joint agency response for the child death review process. So this is very much a multi-agency presentation, and I'm really pleased to see so many people participating. So I can see we've got 131 participants at the moment, and a really good breadth of police officers, social workers, health, and that's really good to see. So before we move on, I'm just going to introduce my colleague, Chris Windsor.
Hi everyone, so I'm Kristina Windsor. I'm the Detective Inspector for Operation Ruby, who deals with child protection for the kind of north of the force. And I've taken over from Larisa as the police panel member on CDOP. She's done an absolutely amazing job for many years, so hopefully I can do her credit. So I will be manning the chat for today. So when you guys have got questions, if you can pop questions in there, what I will do is try and group the questions together and then give them to our panel members at appropriate times to try and avoid us having too many delays and make sure we can get through things, and there will be time at the end for a bit of discussion. If your question isn't answered immediately, it may just be that I'm waiting to group it together, or I may be struggling to keep up because there are an awful lot of you. So if it comes to later and you think it might have been missed, then feel free to pop it back on. So yeah, that's me. And then over to Mary to introduce herself.
Thank you. So I'm Mary Gainsborough. I'm the designated doctor for children's deaths for the west of England, which is Bristol, North Somerset, South Gloucestershire and Baines areas. And so those four former safeguarding board areas come together to review children's deaths through the Child Death Overview panel. And today's focus is really about the joint agency response to those sudden and unexpected deaths and what our role may be. I can't see who you all are, but as Larisa has said, you're from those key agencies involved in this work and some of our supporting colleagues in other organisations. I'm sure paramedics, health visitors, fire agencies, there's all sorts of other people as well as wider staff in the hospitals available. And normally we can see you. We normally make this teaching really interactive. It's a lovely day where we do a lot of, you do all the work, we don't do all the work. So it's a bit strange doing it in this format, but I hope you won't take your thinking caps off and you all just continue to think, how would I contribute to this? How can I bring my skills to bear? So without further ado, we'll go through a bit of an introduction. So this is a quote from Baroness Helena Kennedy, who wrote the original Sudden Unexpected Death in Infancy guidelines back in 2006, sort of at the very beginning of the child death review process, which was then launched in 2008. And she's had an update of her report in 2016. So every family has the right to have their child's death properly investigated. Families desperately want to know what happened, how the events could have occurred, what the cause of death was and whether it could have been prevented. And this is important in terms of grieving. So today we want to go through a little bit of background to the child's death review process in general, and then competency to make decisions about a joint agency response, and then how you might fulfill your professional role in that. This is our national guidance currently, which was published in October 2018 and is the Child Death Review, Statutory and Operational Guidance, and goes through all aspects of the process, which applies to all under 18s and every child death in England. And it's also embedded in working together the response to child deaths. We're going to go through parts of that today, but this is the flow chart that really runs through that guidance. So really it takes us from the moment of child death to then thinking about decisions that need to be taken, about pathways that need to be followed and what has happened, who needs to be involved. So that very immediate decision making in the minutes and hour or so that follows the child's death, and then notifying other professionals and appropriate agencies. And then it moves on to a slower, over the next few days to weeks, gathering more, investigating what has happened and gathering information that is already known about that child and finding out what has happened. This all culminates then in a child death review meeting. for every child. And you see on the left there that really underpinning this whole process from the very start is support for the family and thinking about their own needs, how they can find out what has happened, contribute, have their grief supported, and have a specific contact into the process to raise any questions. And then later on, there will be an anonymous review at the Child Death Overview panel, and that's where we focus on learning from the child's death or from a number of deaths, and focus on local and national learning to prevent future deaths. And we now have the National Child Mortality Database, which is also based at the University of Bristol on behalf of the whole country. So the data, the learning all goes into that to produce national themed reports and hopefully changes to policy. So looking at the immediate decision making, I think Larisa is going to take us through this slide. Is that right?
Yeah, I'll take you through this slide, although I might call on you, Mary, around some of the more medical sections of it. So when we're notified about the fact that a child has died, we might be notified in a number of ways. So it may well be that the child is presented at A&E. It could be that the ambulance call the police on their way to A&E. There's lots of different ways that we as professionals might be notified that that has happened. One of the first things we need to do is absolutely consider support for the family, which is where we take a child is really important, because we'll talk a little bit later on in the presentation around the service that our bereavement care team at the Children's Hospital can offer. And we do have a few anomalies around where we might take a child when they die, and there's another slide that we'll cover to talk about that as well. But what we need to consider when a child has died are the criteria for a joint agency response met, and that's changed with the new statutory guidance, and we'll talk through that in a subsequent slide. In terms of decision making, we may well need to make some very early decisions about what response needs to be provided. For example, if a crime has been committed, we quite actually often miss the joint agency response when there is a murder of a child, or if there's an RTC that's involving a child, because sometimes we forget that children under 18 who have been victims of this criminality or who have been involved in such incidents actually need to be reviewed through this joint agency response and through the child death process. Mary, do you want to just talk about points 5 and 6?
Yeah, so it's very, if there's a medical cause that is known, then it may be possible to issue a medical certificate of the cause of death. Sometimes there needs to be a conversation with the coroner about that. But if the cause of death isn't known and it's not going to be possible to issue that certificate, a referral is made routinely to the coroner. And sometimes that's a separate process to this joint agency response, but they sit hand in hand. And then in terms of thinking about whether there's a service delivery issue, it's just picking up if there is immediately something that has not happened that should have happened within health or other statutory services that needs investigation. And so in parallel, there might be kicking off another type of investigation, such as a root cause analysis within the hospital, or a serious case review, a serious safeguarding review. So we need to bear in mind those things and interface with those professionals.
Yeah, we need to think as well about any actions we need to take to ensure the health and safety of others. So that's really thinking about, for example, if a child has died of infection, is there any risk anywhere else with regards to family? And just thinking about patients and staff, and thinking quite holistically about what's happened and what considerations you might need to make. And then you will need to make some notifications to the Child Death Overview panel via a notification form. And we're going to go through a lot of these things in a bit more detail in the next few slides. So we have produced this sort of pathway for where we would take a child. And it's really important to know, obviously, a child is anybody under the age of 18. And the statutory guidance actually says that every child who dies in the community under the age of 18 should be taken to a hospital. So for us, we just have an anomaly with the Children's Hospital in that they won't accept children who are 17 years of age, essentially 16, 17. So it's absolutely fine if they're under 16. but if they're 16 or 17 and they're in the sort of Bristol area, they may well need to go direct to the mortuary. If the child's in the Bath and North East Somerset area, then the children can be taken to the Royal United Hospital. Is there anything else you want to mention about that, Mary?
I think it's just to say this is guidance, and in individual situations, the professionals involved in that as part of that immediate decision-making conversation would just have to think what is the right thing to do in this situation. So if a child has been particularly disfigured and harmed in an accident, for example, it may be sensible to go directly to Flaxport, and the hospital isn't going to add anything. And bringing the hospital in is often thinking about investigations that might be needed that can be taken more immediately there than in a mortuary setting. And also optimising the support to the family, which is easier in the hospital, but it can be thought about even if it's required to take the child directly to Flaxport. And so those conversations need to take place at a high level between professionals.
Yeah, so it is just guidance, and I think we do a lot of training to our road traffic collision investigators around the individual thoughts that they might have to have at scene as well. And I think Mary's right, it's best practice to go to the hospital because of the services that are provided, but it's an individual decision based on the circumstances that you've got. And this pathway has been shared with our colleagues in the ambulance service as well, so that they're aware of it, so that you can have some good conversations in that immediate moment. Okay, so we talk a little bit around risk factors and when you might need to think about whether there is any criminality involved in what's happened to the child. And these are just some of the risk factors for you to consider, and they are just a consideration. Just because they are present doesn't mean to say that it's definitely a suspicious incident. And also one of the things to think about as well is actually a lot of these risk factors we see are present in children who die as a result of a SUDI, something that we just, we don't know why they've died. But just to think about history of violence to children, once you know who the parents and adults involved in that child's life are. Inconsistent accounts can be quite key in thinking about whether there's something suspicious that's happened. We talk about the toxic trio, so mental health issues, a history of domestic violence, and a history of substance misuse. Also thinking about previous atypical hospital visits. So what do we know about this family? What do we know about any siblings? And it's really important when we come on to it to talk about that value of information sharing between agencies, so that we gather as much information as we can to identify some of these risk factors quite early on. If the child is over 1 year old, it could be suspicious. We know that most sudden unexpected death of infants happen between 2 to 6 months. They can happen older than that. And I think, Mary, do you want to comment on that at all? So we have seen children with a classification of death as a SUDI that are older than 6 months, haven't we?
Yes, it's just thinking a bit harder, isn't it, about other medical causes or other external causes if they're outside of that group.
Lovely, thanks. And so particularly thinking about whether children know to social services, whether they're subject to a child protection plan, what they're subject to the child protection plan for. Neglect can often play quite a key theme. And then whether there are any adults involved in the child's life with a criminal record, or any previous siblings who have died as well. So I think it's just really important to consider these factors and bear them in mind while you're making your decisions. So the joint agency response criteria, this changed with the statutory guidance, and what will happen if these are met is that the on-call health professional, a duty social worker, and the police officer will have a conversation to trigger the joint agency response. So you need to consider it if the death is as a result of external causes. If it's sudden, there's no immediate cause. Where the initial circumstances raise any suspicions that death may not have been natural. If it occurs in custody, or where the child is detained under the Mental Health Act, or in the case of a stillbirth where there's no health professional in attendance. So when we're thinking about external causes, we're thinking about something that could be a murder or a manslaughter. It could be a health and safety type situation. It could be a road traffic collision. If it's something there's no immediate apparent cause and you just don't know, it's absolutely right that there are then health and police investigations to try and establish why that child has died. There may be some circumstances that are very obvious and very suspicious, in which case you trigger the process. If it occurs in custody or where the child's detained under the Mental Health Act, that's very straightforward. In the case of a stillbirth where no health professional is in attendance, this is quite new as part of the criteria for us to respond. And certainly we have seen a rise in free birthing, and we've certainly seen a case within our area where parents have opted out of having any healthcare at all during the birth, and sadly a child was born and died. So this is something that we have seen more of.
And yeah, at the bottom there, then there is also a requirement to trigger a joint agency response if a child is brought into hospital, resuscitated, but then expected to die and may be cared for a number of hours or days even on the intensive care unit. So it's important to think at the moment of presentation about the joint agency response if our intensivist colleagues are giving us that sort of prognosis, rather than thinking about it later, because you're still needing to think about what about the place, what about the scene of the collapse, is there any evidence or information we need to gather? So we try and have those discussions, but it's obviously much more tricky if a child is still being treated and is alive and the parents are likely to be with them in the hospital, possibly crossing a number of different regions if they've been brought to Bristol from a surrounding area. So those are the sort of things that are going to trigger really the process that we're going to describe today. And I suppose just to say that also deliberate or accidental self-harm comes under this as well. So suicides or overdoses or accidental self-harm.
Larisa, there is one specific question around consequences to free birth. Did you want to answer it now?
Yeah, I can do. So Mary and I and our colleagues discussed this at quite some length when we discussed a case involving free birth. The response in that particular circumstance was that there wasn't any legal action to be taken. I think it would depend on each individual set of circumstances for the case. So there's no specific legislation around it, but obviously we would be concerned around safeguarding and just looking at that particular case holistically. So you'd have to treat each one on its individual circumstances.
And it's just a reminder that the whole aim of the child death review process is learning rather than blame. So it is about thinking, well, what could have been done differently in that case? What might have enabled that family to stay in touch with health services and to, they obviously, and what are the health service obligations to provide information to that family despite maybe that relationship breaking down. So that's what we have scrutinised and we'll be trying to change for the future. So it's those kind of learning points that come out from the discussions too.
Okay, so who should be involved? Healthcare and other professionals who have attended at the end of the child's life, the community paediatrician or other health professional, the police and social care, and on occasion the coroner's officer as well. I mean, the coroner's officer is pretty much always involved, I would say. And there are contact details there for people, and these slides will be shared. Mary, I was going to hand over to you at this point.
Indeed, yes. And it is the community paediatrician who is the lead, certainly for joint agency responses for children who die outside of hospital in this area. But you may be aware nationwide that there are different people who have that responsibility on behalf of health. So some have dedicated nursing teams, which may be health visitors or special school nurses. So if you go to other parts of the country, that may change. And as we deal with other regions who input into Bristol, we need to be aware that other people hold those roles. But we share that responsibility, certainly for children who are cared for as part of their resuscitation or at their end of life care in the hospital. Then there are other healthcare professionals involved, and prior to the child's death there will be health visitors, GPs, and maybe specialist teams who also know the child very well, who need to be closely involved and may even end up taking on the lead. So that's our core team. And social care, although are not involved in the teaching today, normally when we do this multi-agency presentation, social care are very much involved in setting it up and are there to field questions as part of the panel. I know there are some social care representatives joining in today, so we'll draw you in as we need to, and are clearly a key part of that sort of a three-way response. So what does the actual joint agency response consist of? So we have a detailed history taken by a skilled and experienced professional. So all of you may want to think this could be you. And you all, although many people, this will be a new area of work, something that you feel a bit nervous about, as we all continue to do, and certainly did right at the beginning. You are a skilled professional, you bring your own training and skills, and they can be applied to this situation as much as any other. And it's really just thinking about what's the information that specifically needs gathering here, but it's very much a generic approach we would to any presentation. There's going to be an examination of the child's body. There's going to be specific medical investigations which we need to consider and carry out, a scene investigation and home visit, possibly, if the coroner's process is going ahead, a post-mortem examination, and then background information gathered from other agencies. And all of this, we just have to bear in mind, this is from the very start, it's the start of us supporting this family and for their journey from this moment on. And we want the experience of how we deliver the whole of this to the family. It's not just in gathering information for us, it is us providing the earliest steps of support for them as they start to try to even understand and cope with what has happened.
I was just going to add, to make sure that each element of that does need to be done jointly. So we talk about a joint agency response, and you can modify the response, but I think it's just important that we note that each element should be done, the history taking examination and the medical investigations, that's all done together in consultation with each other.
So even before starting, you're going to have a conversation with your counterparts in the other organisations. So usually health and police at this point, in terms of deciding how to proceed, bringing social care in to make sure we've got any background information and making a plan about how to go about these different elements. And they don't have to run in this order. Sometimes things happen in a different order according to what seems to flow best. So it's very much having a plan together and working out how to carry that out and where it needs to be. And when we come to meet the family and take this detailed history, it is usually health who take the lead in asking the questions, but we very much value being there with police colleagues to fill in some of the aspects they want to ask more about, some of the bits we haven't covered adequately enough, just checking exactly what we are being told for detail and clarity. So it's very much a joint effort, and the police come without uniform, and they're very much there as part of the support role. And once we have usually explained why this is something that is done in the case of every child who dies, the family usually are able to proceed and accept that as something which is helpful in really trying to understand what has happened. And ultimately, this is all about being really curious. You're trying to build up a mental picture of what's happened and what family life is normally like for this child and parents. So you're going to ask about a description of the event. You may have heard a brief summary already from the ambulance crew or the emergency department, and you're going to pad that out really. So who found the child, when were they last seen alive, and go through a detailed history of, in particular, the past 24, 48 hours for them. So in the case of a baby, for example, what is their usual feeding regime? What are there any behaviour issues? Do they cry a lot? Was that more in the last few hours? Any unusual episodes that they've had, or any unusual observations that the family have had? Who's cared for them? Who was present at the time? What was their bedtime normally like, and sleeping arrangements? What were they wearing? Did they use a dummy? What sleeping position were they maybe placed into, and what were the covers and bedding around? Have they had any recent accidents? So you've already told the family you are going to go and examine them. Is there anything I'm going to notice when I examine them? And you're going to ask about, have they been to the GP or health visitor recently? You're trying to build a bit of a picture about how this family work. Are they anxious about their child? Who do they go to for advice? And as the parents talk to you, you're building up a picture about how they describe the child, how they, what sort of position does the child hold within the family? Are they, is the bonding good? They often nowadays show you some pictures on their phone about things they've done recently to give an example of family life, which is lovely to see. They often talk about the child really in the present tense at this point as well. And then you're going to go and ask a bit more information about the pregnancy, birth and past medical issues. Have there ever been any concerning episodes before, acute life-threatening events? Are they on any medications? Have they had their immunisations? When did they last go to the GP surgery? What was it for? Have they got the red book with them? And as I say at the bottom there, don't try and remember all these questions. There are some pro formas that can remind you all things to ask. And then background, a bit more background about the family, and we're going to ask about the different household members, their occupations, health background. Often comes better from health to ask about smoking, drug and alcohol use, both now and during pregnancy, than if the police ask that, because they'll get a bit suspicious, but they're very happy usually to talk about that as part of the medical history. And then, although we are also going to go and check, we're going to ask the family directly, have you had any social care or police involvement, and just see what their account of that is as part of building up a picture. Kristina, do chip in if there are any questions, but I'll pause again at the end. So moving on to the examination, again, that may be straight away. If, for example, a baby has been brought into the hospital at the end of resuscitation, for example, it often works well if we as a team can go and talk to the family while the emergency department staff are taking samples from the child, and by the time that's all finished is a suitable time for us to go and examine them. And the police also need to go and see the body too. That's their requirement, so we go and do that together. We're going to have a look at the overall appearance of the child at this point, noticing their clothing and hygiene. There may be some post-mortem changes, and what has been described when the child is first found by the paramedics is also important in this. So looking for, is rigor mortis already setting in? Is the body becoming stiff, which happens 2 to 6 hours or so after death, for example, the temperature at that point, and are there signs of libido, which is when there is blood settling due to gravity into the body, which again happens about half an hour to 2 hours after death, but then after a couple more hours becomes fixed. So you can gain some information about what position a body may have been lying in and how long it is since the death occurred. You're going to look at the body for markers of disease, and hopefully what you've been told about the child's past condition, past history, if they do have any medical histories, when you come to examine them, you're just checking what you've already been told, really. You're going to do a top to toe examination, noticing any birthmarks or injuries, and document medical interventions if there are puncture marks from blood taking and other aspects of the resuscitation. Going to check growth parameters, and the body temperature will have been measured in the emergency department. As part of the examination, we do look at the eyes, and in the Kennedy guidance in 2016, there was a suggestion that if you couldn't see the retina adequately, you may want to ask an ophthalmologist. We're having some debate about that locally, and it seems it's probably not going to be helpful. So we just have a go ourselves as the doctor who's there, and then pass it over to the pathologist. But it's worth thinking about, and particularly at this point, you're picking up any clues that are changing the formulation that you've already got in your mind. Right from the very start, you've probably formed a view. This sounds as if it's entirely unexplained. There's nothing that's been amiss about this child's care, but any other things you are hearing are being gathered, and you can change direction at any point if there are any concerning features that are presented through the examination or the history. really you're just trying to see, are there any surprise findings? So the investigations, we have a set list of suggested investigations, and locally we have agreement from our coroner to go ahead and do these. So we're not asking parental consent, but we do want to tell the family that this is going to be done. And they're all with an aim of finding out what the cause of an unexplained death is. And in certain circumstances, some of these may not be relevant. So you can see they're going to be geared at looking towards infections, maybe underlying conditions that haven't been identified in life for this child that have made them susceptible, for example, a genetic or a metabolic cause, or has there been any poisoning? So we're going to do a lumbar puncture, and that's primarily to look for infection and virology, bacterial infection, like meningitis and viral infections. Blood tests, which can be may not be very easy, but the emergency doctors are very skilled at that. And those will again to be looked for culture for infection. If it's fairly recently after death, looking at a glucose, a blood gas, maybe electrolytes and a full blood count. Depending how long it is, that may or may not be possible. Throat swab, nasopharyngeal swab for culture and virology. Urine, which will be taken again from maybe a catheter sample, or may need to be a stab into the bladder to get that, or a collection from the nappy. And again, we're looking for infection, but also collecting that for later metabolic tests, and most importantly for toxicology. The skin biopsy is taken so that we can extract, grow fibroblasts and do later genetic testing, which is important. And depending on what's known about the child's medical condition, it may be appropriate to take other samples, muscle, liver, and we'll have advice about that from the specialist teams. And then a skeletal survey is done as part of the forensic or the coroner's post-mortem. Is Andrew Bamber here? I was going to, our local pathologist was going to join us, and if he is there, he could may have a few words to add at this point. I can't see or hear him, but we keep his number.
I am not sure if you can hear me. Dr. Bamber is trapped in mortuary due to unexpected heart defect.
Okay.
So sending his apologies, and he'll stay in touch later.
Oh, thank you. Are you phoning in from the mortuary team as well?
Right.
Thank you. That's really helpful. And I know you can see it's just helpful for us to phone and speak directly if we have questions about any samples or the timing of any samples. Obviously, it's best to get these as soon as possible. But in the scenario that we've described, where a young person is transported directly to Flaxbourton and there may be some delay then in getting, for example, the infection samples, we need to just consider what are the priorities in this particular situation and what's the likely cause of death. If it's an accidental death, then those infection ones are not going to be so important, but we probably still want to make sure that toxicology is done, but that can be done at the time of post-mortem. And don't forget to look up the results, really. So I just say that because when you've done the history and examination aspects, that's going to be written up in a report and sent to the coroner, shared with the pathologist and the other agencies. And you need to do a follow-up report with these. You are responsible then for looking at these test results and adding those on if you're the health lead. Okay. Any other questions at this point, Kristina?
No, nothing at the moment, not yet.
Thanks.
So I think Larisa is going to take us through then the next stage as we move on to the home visit.
Yeah, so talking about the home visit, again, it's just really important to remember that this is a visit that's conducted jointly. So it's generally the paediatrician and a police officer. And it would normally happen after the examination of the child and the joint history taking. So that's normally the order that it happens in. If it doesn't happen in that order, it doesn't matter, but that's generally the way that it works. And the scene, or where you go, is generally the scene of the death. But sometimes that might be that you go to the scene of the death, but you also conduct a home visits, particularly if you might have concerns about the presentation of the family. You might want to have a look at where the child has died and then go and see the home address as well. So like I said, this generally happens within all of this generally happens within the first 24 hours of the child dying, but the idea is to have this completed within 24 to 48 hours, just to give you an idea of timescales. And it is really the role of the police to make sure that that scene has been secured or preserved as best we can, and having done that very sensitively as well. So we might find for example, with a straightforward sudden unexpected death of an infant, that when the family go to the hospital and the police meet the family at the hospital with the paediatrician, they'll have a conversation to understand who's still in the family home. And we then might ask some colleagues to go to the family home and just see if we can arrange for them to stay somewhere else if there's other family members there, just so that we know when we go to the scene or we go to the home address that it hasn't been changed or there hasn't been anything moved, so that we're seeing it as it was when the child left. So the purpose really is to have a look and see what it's generally speaking in the home, not always, as I've said, but it's just to have a look to see where the child may have collapsed or where they were found or the circumstances of that. And you need to be really sensitive about this. So having an understanding of where it's happened within the home address. And when you go in and sit down and talk to the family, if there's been some resuscitation, for example, in the dining room or in a bedroom, then you're going to find another room to go and sit down and have your initial conversations, and then ask the family to go and take you around the house and to show you the room where the child was found. And generally speaking, it's often in the bedroom, but like I said, not always. There will certain things you'll be looking for when you're there. So when we talk about the sudden unexpected death of an infant, we might look to see what clothing the child was wearing at the time, to see how many layers they were wearing. We might want to seize a nappy. That might be useful if we haven't been able to get any urine from the child at the hospital. We might look at bottles, the red book, and we generally look at taking room temperature as well. So we want to know how hot it was, because it can be a risk factor for sudden unexpected death in infancy. And the way we tend to do that is to put a thermometer in a chest of drawers full of clothing if we can, because it tends to keep the ambient room temperature, just in case a window has been open since the point that they left and then you come back. When you look at taking items from the family home, what I always say when I'm training police officers is, why are you taking it? Really think about what you're taking and why you're taking it. What are you going to do with it? If you're not going to be submitting anything for any forensic examinations, realistically, what are you taking it for? And just to think about the impact that that has on the family when you're in their home and taking things from their home. It can be really impactive. So you've got to just have a sensitive approach and really think through what you're doing and why. You may want to take some photographs, and that's okay. We can take photographs inside the home, and the police officers attending will generally have a bag that we can take from the police station that will have a camera in it. If we want to take measurements of any furniture, there'll be a measure in there. There'll be a thermometer. And also there'll be some guides. So often there'll be a book with some body maps in case we need to help out the paediatrician with a loan of a body map for the examination of the child. And there'll be a guide around some of the questions you might actually want to consider asking parents for the home visit as well. So we have a bag that we can bring with us that will have all of this equipment available. But you're just looking really to see, are you happy with the family home? Does it look okay? Are there any signs of neglect? Does it tally in with what the parents are telling you has happened in terms of the sequence of events? And on the whole, these are visits that can be managed really well, really sensitively, and you will feel reassured afterwards talking to the parents. If it's suspicious, then this won't happen in that way. It would be completely different. So we would then think about securing the scene, and there would be a full forensic strategy. There might be some occasions where actually we're a bit in between. We're not sure if it's suspicious, but we're not completely happy. Again, we always try and have a very low-key approach, but what we might do is ask the family if we can have our crime scene examiners come in to take some photographs, do some measurements, and there may be some other things at that point that we consider whether we need to see, such as mobile phones or something like that. But I would say if you're going down that road, then you're thinking it's suspicious, really, and that decision making is quite important, to be clear what you're doing and why you're doing it.
Yeah, it's very much an evolving process, isn't it? So we have this, this what we expect to happen, but then as information comes to light, we can take things off and examples in a different direction. So examples I can think of, while we're at the home, there's a call from the hospital to say that a substance has been detected on a toxicology sample, and then there may be a need to do a more thorough investigation in the home to look for substances, or even to request parental samples, for example. Or when examining a child, you find a bruise that you hadn't expected, and then there's going to need to be a bit more explanation back with the family about that, or thinking where that came from. And there may, again, there may be a benign explanation, but it's just gathering everything you see into your sort of the story that you're putting together.
And it could be as well, I mean, certainly with an RTC, you may well decide that you don't actually need to do a home visit, because you might find that you've had some conversations with parents, you're absolutely happy with the presentation of the parents, the scene would obviously be on a road somewhere, and if there's no safeguarding concerns, you might not need to do a home visit at all. So, like we said, this process is modifiable, and you can modify it, you can change it around. You just document, if you are changing it around, why you're doing that, the reasons why, and just document it clearly.
Thank you. So I think what we're going to move on to now is a bit of an example and some role play, change from our faces. So we're just going to take as an example a sudden unexpected death in infancy of a 5-month-old boy. And we're going to listen to a community paediatrician who is very kindly Dr. Sarah Dawkins, and police. So we have DS John Underhill, and they're going to have a phone conversation about this case for us to listen to. Are you ready there? All platform is yours.
Okay, hi, I'm Sarah. I'm just going to start by ringing 101. Hi, could I speak to the duty DS on call for child deaths for Bristol, please?
Yeah, good morning. It's DS Underhill from Operation Ruby. How can I help you?
Hi, my name's Dr. Sarah Dawkins. I'm the community paediatrician on call for today. I've got some bad news from ED. There's been a child death in the early hours of this morning, I'm afraid.
Oh, that is sad. Can you tell me some details, please?
Yeah, sure. So it's a 5-month-old baby called Billy Webb. Date of birth is the 3rd of May, 2020. I've just had a call from the ED consultant down there at the Children's Hospital. This baby was found unresponsive in his mother's bed at about 8 o'clock this morning.
Mm-hmm.
So mum's name is Connie Mathers. You want her date of birth as well?
Yeah, if you give me that, then I can run her through the system for a quick check.
Great, it's the 1st of August 1998. So she lives with Lee and his older brother Nathan Mathers, whose date of birth is the 12th of September 2016. So mum reported that she put Billy to bed as usual. He woke for a feed about 3 in the morning, and she brought him into her bed for a feed, and then woke at 8 to find him in the bed unresponsive, lying on his front with the duvet over his head, at which point she immediately called an ambulance, who arrived in around 4 minutes. The ambulance started resuscitation when they arrived, but then quickly decided that Billy had been dead for some time, and they declared death at the scene.
Okay, excellent, thank you. I've just done a quick check on Connie. I can see that she hasn't got any criminal records, but the residence that she's at has previous for possible drug dealing, but that's unsubstantiated. But I'm sure we can follow that up when we do the home visit a bit later on.
Great.
So the next steps then, taking forward the JAR process.
Yeah, so the ED consultant is kindly collecting the KBSP samples at the moment. I'm at home today. I can get into the hospital in about an hour if you'd be happy to meet there.
Yeah, that's excellent. That works out really well for me as well. I'll do some more checks as well, so I've got plenty of information that I can give you when I get there. Are you happy for me to contact the coroner between now and then?
Yeah, that sounds a really good idea. Shall I ring EDT then? Split the work?
Yeah, excellent. And hopefully if you just pass on my details to them, I can have a conversation with them as well. It just gives me a little bit more of information to work with. Okay,
great. I'll give a call to the bereavement team as well before I come across to the hospital, see if they can come down and see Mum. She's in ED at the moment.
Yeah, that's brilliant. Thank you. I'll pass on my mobile phone number to you in a minute, just in case there's something happens and I haven't turned up or anything, and I'll come and find you in the emergency department.
Great, that's perfect. Do you want to talk about the home visit now, or should we discuss that later?
We can discuss it later, but if you want to have a brief chat about it now, that'd be okay.
I'm just thinking about timing. Do you think we'll be able to do it today, or would you rather wait until tomorrow?
I think we really need to just look at what the circumstances and how the parents present and what our feelings are. So we can make that decision as we're going along. And obviously between me and you, we can have that discussion. I would like to do the home visit today if we can, but if something happens that we can't, then I'll put something in place to make sure that it's secure for us so no one else tampers with it.
Okay, fine. The only other thing that I would need to check is about where Nathan, the 3-year-old brother, is at the moment. I think he's with grandparent, but just need to make sure about that.
Okay, well, I can make some further phone calls to EDT and just find out exactly what information they know, and if we need to, we can give grandparents a ring.
Perfect. That sounds great. Thanks, John.
No worries.
I'll see you in about an hour.
Yeah, see you in an hour. Take care. Bye-bye.
All right, bye.
Thank you both. I think that was really helpful in just illustrating the sort of things that need to be considered at the time scale. And certainly from the situation you've described there, thinking about the taking of investigations, and you described the emergency doctors getting on and doing those. You mentioned the sibling, and there would obviously within the discussion with the emergency duty team be a need to think about any safeguarding considerations in particular regarding the sibling. And then you did also talk about the scene preservation and doing that in a subtle way before then maybe going home with the parents later on. And then you also brought in the bereavement team to start providing the family with some support and thinking about their needs, and then thinking about when they go home, who would support them when they go home at that point. Well, it's mainly the mum here in this situation. Thank you. Chris, are you okay with any other questions arising at this point?
No questions at the moment.
No. Thank you. That was great though, you two. In terms of say a bit more about family support, so through the child death review process, there should be a key worker for that process identified for every child who's died, so that the family really have a key contact point that they can expect to hear what's going to happen next. Obviously, right at the beginning, knowing that there's going to be a meeting at the end called a child death review meeting is not going to mean anything. So they will need just supporting with what is needing to be happening that day and immediately. And later on, maybe having some more information that they can submit questions and have them answered through that process. And we do rely a lot on our hospital bereavement team for children who've been through the hospital, and they're also willing to be involved in supporting young people who die outside the hospital, even if they don't come there, fortunately, on a case-by-case basis. But children who already have an underlying condition may have a specialist medical team involved who are very much lined up and already know the family and can act as their key worker, particularly under the specialist medical teams at the hospital or the palliative care agencies. And even children who have a chronic illness may die in unexpected circumstances and hence be having this sort of investigation on top of what is already known about their condition. And the family liaison officers obviously have a role for children following road traffic accidents and other suicides, other community death.
So predominantly a family liaison officer will be allocated from our roads policing officers if a child dies in a road death. If a child is murdered or dies as a result of manslaughter or that sort of similar criminality, then they would also have a family liaison officer. But in all other circumstances, the police liaison will be the police officer who's taking part in the joint agency response.
Thank you. And then providing obviously written information for the family who won't be taking a lot of this in at the time, but so they can read back in their own time about, you know, they're going to suddenly have to hear about a whole load of different terminology they've never come across before. What are the practical arrangements? What do they need to do next? What about certification? What the coroner needs to do? How can they go back to the hospital to visit the child's body, and what to expect next? Just to touch on some other considerations, because, you know, there are infinite varieties. Every child situation is completely different, and we come across new things all the time, unfortunately. But thinking about informing other agencies, so for that core team to think, often if it's overnight or at a weekend, how can we inform the school before they next open? How can the school be supported to think about supporting other pupils in sharing that information and counselling them afterwards? Can they contact the local authority, get some help from educational psychology, for example, and be helped to manage what to say to the media? This year, we've obviously had to adapt this process and think how COVID affects this operation. There have been home visits despite COVID, actually, because it's the most appropriate way to do so. But we've also had meetings in other places and, if necessary, by phone or on virtual platforms. But trying to carry out the key elements of the joint agency response from the start. And in this area, we worked very quickly in March to make sure that this process was thought about and would continue to be able to be offered. We do have to think about whether a child has had COVID, or probably more likely has some aspect of lockdown and restrictions influenced the events around death in terms of seeking medical attention or emotional well-being issues. And so it's very important to note those. We've talked already about children who are resuscitated and taken to hospital but expected to die later, in which case the attending medical team are going to be in a much better place to ask all these questions as part of, not necessarily right at the beginning of the admission, but as part of gathering information about that child while they're in hospital. And for children who have sustained a non-accidental injury and also die later, or for children in care, then really the joint agency response is very essential. And this may be years later, actually. So there may be children who have sustained a brain injury, for example, and their death is some months or years later on down the track, but then it's still very important this process is considered. Unfortunately, children sometimes who live in our area die abroad, and this process still needs to be triggered in a modified way so that we're still able to gather as much information as possible, challenging though it can be across international boundaries. Children with learning disabilities will come under the leader process too, and we have reciprocal arrangements to share information, but we will primarily do the initial investigation in this way and then contribute to this statutory process. And as we've said, 16 to 17-year-olds are included, but may be cared for in adult healthcare settings. So it's our responsibility to make sure that our adult hospitals and colleagues are also aware of this and how they would need to trigger a joint agency response and contribute to it. Within the adult hospitals, there's a learning from deaths framework, which now provides their overarching pathways for review. And there's some overlap in those to make sure that the child death review process is also followed. And just to mention, next year, the medical examiner process will become statutory. It's already in place for adult deaths in hospitals, and this is a process to review certification of deaths and to make sure there's increased consistency, and certainly within adult care to make sure that the bereaved families have opportunities to raise any questions. Now, many of those things are already happening through the child death review process, but the medical examiner process will also apply within paediatrics. So we're working with the teams locally to make sure those processes interface. So just keep your ear to the ground on that one. Any other questions?
There are a couple of questions. I don't know if you want me to give them now or wait. So there's
now.
one around the flow. I know that Larisa talked about the flow, and Amanda's asked, in suspicious circumstances, is there guidance for the officers on what contacts should or should not be made with parents in terms of flow type updates?
I mean, in suspicious circumstances, the flow is going to work really, really closely with the investigation team. So the strategy for the family liaison officer is going to be set by the senior investigating officer, and it will all tie in really, really closely. So that will all be agreed formally and documented in a policy decision.
I've got one other one for Mary, and it is if a child dies outside the area they're normally resident in, which agencies will lead the jar, the home ones or the ones in the area where the child died?
So it's primarily the responsibility of those in the area that the child lives. But if they've been brought to Bristol, for example, as part of their care, or if they've collapsed, while on a holiday, or as we've sometimes had, passing through, travelling, on the motorways that go through our area, for example, then we are likely to be involved at the start in close liaison with those people. So if the child's being cared for in a Bristol hospital, it's very likely that local Bristol professionals will need to be involved in the initial history taking, examination, investigations, but the scene visit and the later meetings may well be carried out in the local area. So it's trying to establish contact with them at an early stage and sort of sharing out responsibilities.
And it's probably worth noting that actually we as the police in Bristol get asked regularly to carry out parts of the process on behalf of other forces. So albeit there's statutory guidance that you would think absolutely translates into the same process across the rest of the country, of course it doesn't. And there are different sort of variations of how the process works in different force areas. So in Devon and Cornwall, the way they do things is quite different to the way that we do it in Avon and Somerset. But because we have a lot of children coming into the children's hospital, we have produced a document which sort of defines what the expectations are. So especially for the bereavement care team who might be having to explain to a family what's going to happen next, what we've had in the past is they've talked about what would happen next from an Avon and Somerset perspective, but actually the child lives in Devon, and what happens next is quite different. So we've documented all of that, and that's been shared with most of the officers who are involved in the child death process, so that if we're being asked to help another force do something and it's different to what we would normally do, that we understand why they want to do it. And it's quite often because coroners set slightly different processes around what they want to see happen in their area.
I think it just illustrates again the need for the planning and making a plan of how this is going to fall out, who's going to do what, reviewing that and making links with those other organisations from the start. And a bit of flexibility really and creative thinking to make it work. It's better if two teams are working together than everybody saying, no, it's not my responsibility.
There is one other question around free births, but I think we can leave that till the end when we have the other questions.
So I was just going to take you through some of the forms related to the child death review process. They were known as A, B and C for those of us who've been around for a little while. But the first step, they're now just called by what they do. So the first step is notification. And again, it's more important, it's better that more than one person does this, but certainly that core team needs to decide who's going to fill in this notification form. And that's just to let the child death office centrally know that the death has happened, so they can open a file and start to gather information. And then the reporting form is that over the next few weeks, really, where everyone who has known that child before they died and has been involved in their care around the time of death is given a separate link to fill in a reporting form with all the information they know about them. And then there's an analysis form. This is filled in later on down the process when everyone comes together to share their learning and findings from the case. And this form is drafted at that meeting and then completed at the anonymous child death overview panel for identifying information and lessons for the future. And that's then the final output of this. They are statutory forms. And we provide, from the Child Death Office, we provide support for people who haven't used these forms before, because they're you know, just, there's a bit of an act to using them the first time, how to log on, create an account and save your form and submit it. So the first one, it's worth having a bit of time, more than a couple of minutes to fill it in when you sit down to do that, because you're going to need to write a little bit of a paragraph or two about what has happened and have all the details available, particularly of the family and other professionals. This will form the basis for the Child Death Office then requesting those reporting forms. So if you haven't taken care to really put down all the different people who are involved, then the Child Death Office won't know to contact them and they may be missed later on. You can always phone and add people on, but it's good if you can get it all in one place. That's the link to deaths in the Bristol area. And that office is always happy to tell you if it's a child from another area, which link should be used. And this, as you see, is this electronic CDOP platform that we're now using and is used in many parts of the country. And as you'll see, the three forms really map then onto so here, notification, reporting and analysis. That's just to remind you again of the flow. So we've talked all the way through this for our case example now, and it will be some months ahead that there'll be a child death review meeting. Often the things that need to happen in between are investigation, medical investigation results, including the autopsy result, which can take some time, particularly if additional specialist aspects are needed. And there may be also an inquest going on, which will probably happen after the child death review meeting, but keeping in touch about the timing of that investigation. But over on the left now with the red box, just thinking about the support for the family going on alongside all of this, and then leading to the child death overview panel at the end. The child death review meeting itself is a multi-professional meeting where everybody's observations are brought together, involving the professionals directly involved in the care of the child and their investigation afterwards. The parents aren't part of that meeting. That's just kept the same for every case. So there's no sort of feeling that we're choosing which ones are appropriate for parents to be part of, but there is a second meeting after this where some key people who know the family best can feedback the discussion to the family and answer any of their questions that have been addressed in that meeting. And the review really in its extent should be flexible, proportionate and focused on learning for the future. So I think that's the end of our planned content. And I'm sure there are some more questions from you all, but there's some local contact numbers which may be useful for you to know about there for ourselves and some colleagues. Thank you all for listening, and we may have some additional interesting discussion to follow.
So I do have one question.